Good day everyone. So today we will walk you through the educational pamphlet we made about the integration of orthodontics and oral surgery. So according to Orthodontic Preparation for Orthodontic Surgery by Dr. Abdul Reza Hamilian et al., orthodontic treatment goals can be divided into 5 categories: facial aesthetics, dental aesthetics, functional occlusion, periodontal health, and stability. Nevertheless, when a severe skeletal deformity exists in non-growing teen and adult patients with a significant skeletal jaw discrepancy, the goals of treatment are often impossible to achieve by orthodontics alone. In these circumstances, both orthodontics and surgery are required to correct the dental malposition and the skeletal disharmony. This corrective jaw surgery, also called as orthodontic surgery, is performed by an oral surgeon to correct a wide range of minor and major skeletal and dental irregularities, including the misalignment of jaws and teeth, which in turn can improve chewing, speaking, and breathing. Orthodontics in conjunction with orthodontic surgery can do wonders in improving the appearance of the face. So in this video, we will be focusing on the interdisciplinary approach to the management of diastemas, a novel classification and a case report. It is important to note that an extensive search of the literature till date has revealed an existing classification for midline diastema based on the location and position of teeth. The relation between the proposed contact point and interdental bone level, while the soft tissue position has not been addressed in this existing classification. Hence, we propose ATAC, Anatomic and Therapeutic Approach Classification for Diastema Management involving a restorative perio approach. The aesthetic management of diastema is a restorative challenge and may require multidisciplinary approach for a successful outcome. Diastema can be attributed to developmental anomalies, tooth arch length discrepancy, and habits. In clinical practice, patients often present with complex anatomical situations involving variations in tooth morphology, location of the tooth or gingival margins, and loss of interdental soft tissue. The treatment options include orthodontic correction, restorative correction using composites, prosthetic correction using veneers or laminates, or a combination of the above. On these two sections, first page and the second page and the middle section, you can see before and after photos of the patient's teeth, pre and post surgery. It shows the case history and the progression of the patient's dental health as seen in the images. Let's begin with the facts of the case. A 25-year-old male patient reported to the Department of Conservative Dentistry and Endodontics with the chief complaint of spacing between the teeth in his upper and lower front teeth. Preliminary examination revealed no facial asymmetry or temporomandibular joint abnormality. Assessment of the lip morphology, lip length, and lip line were made. The lip volume was average with a lip symmetry. During resting smile, an incisal show of 3 mm, and on full smile, interdental papilla and 0.5 to 1 mm of the marginal gingiva were visible. And intraoral examination revealed diastema in the upper and lower anteriors, with a tooth length to width ratio discrepancy in the uppers. Overjut and overbite were 4 mm and 3 mm respectively. Soft tissue examination revealed a high frenal attachment between the maxillary central incisors. As a part of the pre-planning protocol for the gingival zenith correction, an assessment of the following clinical periodontal parameters were made: gingival biotype, probing pocket depth, width of keratinized gingiva or attached gingiva at 3 sites in the buccal aspect of the teeth, bone surrounding, and biologic width. The proportion gauge, T-tip, was used to assess and record the crown dimensions for each tooth form, from the left maxillary canine to the right maxillary canine. Further analysis on the soft and hard tissue components of the smile was done with photographs and study models. According to the proposed ATA classification, the clinical scenario in this case report falls under Class 1A, an interdisciplinary treatment plan involving frenectomy, crown lengthening by flap with ostectomy, followed by diastema closure with composite resins was implemented. A papillary penetrating type of frenal attachment was observed between the central incisors. Frenectomy was done with a 940 nm diode laser, continuous wave 400 fiber tip in contrast. Mode and no sutures were placed. Based on the preoperative assessment, crown lengthening was planned. A surgical stent was prepared with clear acrylic in the maxillary study model. The gingival zeniths were created at their new position in the stone model with the help of the tip of the true gauge, and the surgical guide was trimmed to this level. The prepared surgical guide was transferred to the plain incisions at the new gingival zenith positions in the maxillary arch. This was followed by the clavicular incisions and flap reflections to assess the underlying bone. The bone sounding tip of the true gauge was used next to determine the amount of marginal and interdental bone to be removed with reference to the incised flap margins, enabling the reestablishment of the biologic width. The bone removal was done using a number 6 round burr and a slow-speed micromotor handpiece under the cold saline irrigation. The bone sanding tip was used to ensure the bone margin was at least 3 mm away from the incised flap margins after ostectomy. The immediate post-operative assessment was performed with the true gauge to demonstrate the corrected crown, height-width ratio in upper right lateral incisor. The flap was then approximated with 4 0-vicryl resorbable sutures. Post-operative medications was prescribed, and an eventful healing was reported at the 3-week post-operative visit. Following periodontal procedures, the restorative management of the diastemas was planned. A biomimetic approach was incorporated considering the width length of the tooth, location of the contact point, and the relationship of the contact to the interdental crestal bone for a predictable outcome. The width of the central incisors was calculated by the width equation and the length to width proportion. A wax mock-up was made, which served as a patient education model as well as a guide for the restoration. Quadrant isolation was done with a heavy rubber dam for premolar to molar. No tooth preparation was done prior to the adhesive treatment. In order to stimulate the aesthetic appearance, the most suitable shade A1 was selected by composite button method prior to tooth dehydration. The teeth were etched with 37% phosphoric acid, rinse and air dried. Universal bonding agent was applied, dried to avoid pooling of the adhesive, and polymerized for 20 seconds with an LED curing light, according to the manufacturer's instructions. With the wax mock-up, a putty index was made with addition silicone. This index was then transferred intraorally, and a palatal shelf was created with a transparent shade resin. A contoured sectional matrix system was used for the proximal restorations, with one end slightly tucked into the sulcus. Composite diastema closure was done in the maxillary anteriors. The gingival harmony, smile line, degree of tooth display, tooth inclination, and the symmetry were evaluated after removal of the rubber dam. Similarly, quadrant isolation was done for the lower anteriors, and a freehand diastema closure with A1 shade composite was done. Finishing was done with proximal strips and ultrafine diamond points in a slow-speed handpiece, followed by 30 fluted tungsten carbide burr. Horizontal and vertical micro and macro anatomy were incorporated in the planar area under magnification 3.5 magnifying loops. Polishing of the restoration was carried out using Optrapol kit shows the preoperative, post-surgical crown lengthening, composite diastema closure, and the immediate post-operative profile of the patient.
This paper has brought a new classification for diastema and its management with a perio-restorative approach as its principal concept. The classification proposed has considered the harmony of tooth dimensions and the gingival tissue margins to provide definitive treatment options which can be applied in a day-to-day practice by clinicians. The importance of soft tissue component with respect to the diastema has been overlooked in the previous classification. In the existing classification for the management of diastemas, the position of the interdental soft tissue and the gingival zenith weren't addressed. Also, specific and stable anatomic landmarks were not described in the previous class. Choose proportion gauge was chosen and gives a visual objective representation of the recession aesthetic dental proportion of 78% height to width ratio. The instrument has a T-bar tip, has a color coding for teeth with red for central incisors, 8.5 mm in the width and 11 mm in length, blue for lateral incisors, 6.5 mm width and 8.5 mm length, and yellow for canine, 7.5 mm in width and 9.5 mm in tip was not used in this case as there was no crowding and length and height measurements of the teeth could be measured simultaneously with the T-bar tip. Hence, the choose proportion gauge is an ideal instrument enabling quick chairside assessment during preoperative, intraoperative sessions and clear communications between the periodontist and the restorative dentist. Frenectomy was done with diode laser 940 nanometer and using a 400 micrometer fiber tip to dissect the fiber attachment in the inner aspect of the interdental soft tissue, leaving the outer aspect undisturbed. This preserved the interdental soft tissue during healing and enabled to predictable aesthetic following restoration for diastema. Crown lengthening was performed by flap with osteotomy procedure as there was sufficient width or keratinized gingiva or to ensure restoration of biologic width after healing of the flap. A crown lengthening procedure was required to achieve the ideal crown height to width ratio. Since the patient's teeth were wider mesiodistally, the choose bone sound gauge was used to ensure biologic width was reestablished after the soft tissue incisions were placed to restore tooth dimensions. The establishment of an ideal in contact position and interdental crestal bone has a symbiotic relationship to supporting. Important considered is the contact relation to the interdental bone, which helps to avoid black triangles and impingement of the biologic width which forms the basis of the biomimetic restoration. Since there are no ideal dimensions relative to crown length and width ratios, approximation studies have revealed that the tooth proportion range from 72% to 81%. Hence, keeping in mind that the above-mentioned concept and the preoperative smile analysis, a wax mock-up was made on the diagnostic cast. The universal adhesive system used had a superior bond strength to enamel compared to the adhesive systems. The palatal putty index method reduced the chairside time and aided in transferring exact tooth dimensions during the diastema closure. Maxillary midline established with reference to the facial midline and the maxillary philtrum, which is the most reliable landmark. Maxillary central incisors are usually the keystones for an ideal smile designing. Preoperatively, the maxillary and the mandibular midlines did not coincide, having a preoperative midline shift of the lower arch towards the left. The treatment plan could have included orthodontic treatment to equalize the spaces and correct the midline, followed by restorative and periodontal intervention. This was the first line of treatment suggested to the patient. However, the patient was not willing to the orthodontic treatment. Therefore, patient autonomy was followed according to ADA Guideline, Section 1. So a resto-perio intervention was planned to obtain sustainable results within the limitation of evidence from published literature states that the discrepancy of dental midline up to 4 mm do not get perceived due to the reduced visibility and the uniform size of the lower anteriors and hence do not appear anesthetic. In this case, the diastema closure was carried out with reference only to the facial midline corresponding to the maxillary arch. In conclusion, this case report suggests that the use of proposed classification as a template for a multidisciplinary treatment approach to achieve optimal function and aesthetic results in diastema closure. The choose proportion gauge was interchangeable tips represents an ideal and easy-to-use tool that provides a clear and objective communication between the different special clinical significance. A classification involving interdisciplinary approach for management of diastemas in situations which do not demand an orthodontic intervention or when patient is not willing for orthodontic intervention has been presented. To achieve ideal aesthetics, an interdisciplinary approach will be the best option for predictable results. Lack of a classification for management of diastemas in the literature led us to create a novel classification for its management, involving restorative and periodontal procedures. This can give an idea for decision making in smile design. We hope you have learned in this brief discussion about our educational pamphlet. This has been Matthew Jules Palongpalong and Christine Marie Caño from Southwestern Finmo. Thank you very much for listening. Have a nice day.